Hi, everyone, and thank you for tuning in to this special HS Awareness Week episode of the Real Heroes Don't Wear Capes. I'm Stephanie Carter here with Crystal Sutherland and Michael Weens from the HS Heroes team. And today we're joined by special guest, Dr. Rayed Al-Hussein. Dr. Al-Hussein, if you could please introduce yourself to everyone.
Hello, everyone. My name is Rayed Al-Hussein. I'm a dermatologist at Sunnybrook Hospital in Toronto and at the University of Toronto. I do specialize in hidradenitis suppurativa, and I run a subspecialty clinic in the city.
Crystal, why don't you start with one of your questions?
So I did get the pleasure of attending and seeing your presentation at the Skin Spectrum Summit, and I know one of the things that really caught my eye, it wasn't your presentation, but it was one of your colleagues, was they were talking about, how representation matters with picking a dermatologist, and they had some data on how if there were so many patients in Ottawa and there were so many dermatologists there, and if a Black patient wanted to see a Black dermatologist, the amount of patients that these few handful of dermatologists would have would be just extremely insane. And so everybody's really making an effort to educate all dermatologists. So I thought that was really interesting, and I was wondering if you see that in your clinic.
Terrific question. So certainly the underrepresentation of diverse physicians with diverse backgrounds is an important aspect or a challenge in healthcare, because that is usually helps a lot in providing care for patients from diverse backgrounds as well. We also know that certain diseases can present differently in different skin tones, but there are also the cultural component to it, where certain diseases might carry more significance for people from certain backgrounds compared to others. And being educated about that would be quite helpful in providing the appropriate care for those patients. So that's been identified as a challenge for a long period of time. The good thing is, in the last few years, there have been some efforts to try to address that. For example, at that level of the medical school, in terms of including components about dermatology education, that includes diverse skin and how different diseases present in different skin tones and skin types. In addition to that, the different dermatology societies are introducing equity and diversity committees. I'm glad to report that I am part of the EDI committee at the Canadian Dermatology Association, and they've been certain projects or efforts that are we're hoping will result in long-term meaningful change. These include initiatives related to the educational offerings to ensure that those offerings do address the skin presentations in different skin types and different cultures, for dermatologists to be competent in providing care for patients from different backgrounds, in addition to efforts to increase representation within those societies for dermatologists from different backgrounds as well. So it's a long journey, but we're certainly optimistic with the changes that we've been seeing in the last few years.
You just mentioned how different dermatological conditions present differently on different skin tones. Is there a way HS manifests differently on different skin tones, or?
Yeah, so certainly HS can have different presentation. I can think of two important examples. Number one is when we talk about inflammation or active disease, usually the signs that you're referring to, which is, oh, it's a red inflamed lesion, that red tone is most visible in white skin patients. In patients with dark skin, they're not going to have that red color. Actually, it's going to be slightly different. It could be dull, could be darker color, or it could be purplish color as a sign of inflammation. So if a dermatologist is not really trained or equipped with that understanding, they might miss signs of active inflammation. The second part is that skin of color patients can be more prone to scarring and keloid scarring. And that is important in terms of trying to optimize care early on to prevent that late complication of developing in those patients.
That was going to be my very next question about keloid scarring and if the development is higher in skin with melanin. Are there more complications that arise with keloid development when trying to heal skin with HS?
Yeah, so the issue with the keloid is, unfortunately, we do not have effective treatments for keloids. The most effective is really prevention, and prevention through early diagnosis and early effective treatment. In addition to the keloid formation, is patients with darker skin are more prone to have what we call post-inflammatory hyperpigmentation. So following the inflammation, they have darker skin changes at the sites of previous inflammation. And that can be quite bothersome as well and impactful on patients. So that's unique to skin of color patients, or more common in skin of color patients compared to patients with lighter skin tones.
So would surgical intervention affect darker melanoma patients more, especially if there is a buildup of keloids? Like if the tracks start getting further along, is that a little bit more complicated when looking at a surgery on a Caucasian, I guess?
Yeah, especially when it comes to the keloid formation. So if a patient is more prone to keloid formation, the surgeons are quite careful about surgery and can be more conservative because of the concern of formation of more keloid scars following surgery. Now, to be clear, the keloid formation is not unique or isolated to skin of color patients. It can happen in all skin tones, but it tends to be more common in skin of color patients. I would say that most of my HS patients who have keloid formations they have darker skin tones. So that is something where it's one of the common questions that are asked in terms of evaluation pre-surgery is whether the patient is prone to keloids with previous surgeries or previous trauma, because that is taken into consideration in terms of surgical planning.
I have a kind of a follow-up to that. So there was an article that came out in one of the journals of medicine this week, and it was saying like as we know, but not everyone may know that, HS does run in skin of color more than it does in lighter or white, I guess, patients. And since we do know that, is there research going into patients with skin of color? You would think that if the majority of patients, were in that group, that there would be some research into that specifically.
Yeah, and it's another terrific question. There's a huge gap under NHS in general, but certainly NHS in skin of color patients, and there are multiple reasons for that. Well, we talked about how skin of color patients are underrepresented in clinical trials. And those are the trials in which new medications are being introduced. And so we don't have as much data on how they respond to treatment from those clinical trials. But what needs to be done is how we rely on real world data. So that is where in our clinical practices, we're collecting data about patients from diverse backgrounds and trying to identify answering those questions. So are they different in their presentations? Are they different in their disease severity? Is there a difference in the comorbidities in which those patients might have compared to other patient groups? And then how do they respond to treatment? Is there a difference in responding to treatment? Race and ethnicity is part of it, but certainly other factors. And we need to look at all of those to try to develop a more personalized treatment approach for our patients.
Before we started filming, we touched briefly on how patients are kind of divided in clinical trials according to backgrounds. I wonder if you could maybe go over that again.
Yeah, so I want to go over three things related to race and ethnicity in clinical trial and NHS. Number one is we know that data coming from the US showing that African Americans are 3 times more likely to have HS compared to white patients. The second finding is about representation or participation in clinical trials. About two-thirds of the participants in clinical trials are whites or Caucasians, while only 15% of participants are African American. Compare that to the prevalence in African Americans compared to whites. The third aspect of it is how data on race and ethnicity is captured in clinical trials. Currently, the categories that are used are very limited in their ability to capture the diversity of HS patient populations. And I'm going to use 2 examples. The first is there's a category called Asian patients. And that Asian patient category includes everyone from China to Southeast Asia, Philippines, to South Asia, such as India. And to us, that might not, we don't think that is really granular enough to represent the diversity of those patients or to be able to identify differences that might happen in the way that they present with the disease or how they respond to treatment. The second category is white patients or Caucasians. And technically, anybody from the Middle East or North Africa goes under that category. And the problem with that is, again, what we see in clinical practice is those patients tend to have different disease profile in terms of the disease severity and the way that they present, but it would be much better to have more accurate data that is based on research rather than clinical observations. Our clinical data here in Toronto does show that about 1/3 of our patients are of South Asian descent, and another third are of Arab descent. So those patients are not going to be captured, even if they participate in clinical trials. They're not going to be captured in the current classification that is being used.
It's just kind of crazy to me that a lot of this data comes out of the States when, they don't have a public healthcare system down there. So I feel like so many folks that do have, a lower socioeconomic background aren't even going to be privy to a lot of these studies because they won't be able to afford the care, let alone if, you're working somewhere where you can allot to take off time to get the care because either you don't have transportation, you could lose your job. I just feel like there's such a huge chunk of folks that are being left out that don't even, get to try it or get to be a part of that.
Yeah, and there are multiple aspects to this in terms of accessing care. One is physically accessing care. So being able to transportation to travel to your appointments, having the ability to take time off work to be able to attend those appointments or to provide childcare while you're attending those appointments. That is one aspect of it. The second aspect is it is nice that the patients are able to attend their appointments, but if they cannot afford the medications, that's another challenge that need to be addressed. And then the third aspect is getting the message out there to the different parts of the society about HS and what is new in HS. So those patients with the disease go and try to access care. Because if they're not aware of what's happening and what's new in the treatment, they might not seek care for the disease until it's very late, which makes it much more difficult to manage their HS.
I feel like a lot of our time is spent telling people who are saying no one's looking into HS, no one's doing anything to help HS patients, and it's us coming back and saying they're doing a lot. Check out the SHSA conference, check out all these different things that are available to you. So hopefully the work of HS Heroes and the other patient groups are leading people towards this path of being able to, advocate for themselves and find the doctors who can help them.
Yeah, and what the patient organization are doing there is an amazing work in terms of raising awareness about the disease, and we certainly see it in clinical practice, where patients are seeking help and they're using they are the ones who are advocating for themselves. They're in terms of asking to be referred and seeking care. In addition to that, I think still there are a lot of efforts need to be done in terms of different messaging and different tools to reach out patients with the disease to get the message out so they can advocate more for themselves and seek medical help.
There's a huge trend right now going on. I'm seeing it on a lot of TikTok and different things where there's HS influencers and they're really, pushing the diet and not the medication aspect. And for me, I just feel like that is also to like shame folks that can't afford diet like that. If you're in a food desert, if you're relying on a food bank for your food, there's a lot of folks that can't afford to eat that way, where here, we do have patient support programs that will pay for the medication. How do you, placate back to the people who are really just like diet, diet, diet and shame folks that go on medication?
Yeah, and that's a very tough conversation sometimes to have. And I think diets probably can play a major role in HS. It's just we do not have enough data to show that. We certainly need more research. And what I tell my patients is, yeah, certainly we can explore that, and you can explore it, but I think we can do that at the same time that we're doing the medical treatment. Because we have very good data about how effective the medical treatments are, and combining that with sometimes experimentation with diet and avoiding certain foods can be helpful. What I tell the patients usually is some of the claims that are being made about certain diets, right? There's no data or evidence to support those claims. And my concern is if the patient focuses on that aspect of the care, that might result in delay in accessing more effective treatments. We know some of those diets, their impact might be through other pathways or through its impact on weight loss, for example. But we certainly need more data about this. There's some data about like Baker's yeast, for example, in some patients, they actually have antibodies against it and can contribute to their flares and disease activity. But beyond that, we have limited data to avoid certain foods or go on a gluten-free diet or like specific very restrictive diets that can potentially cause more harm than benefit for patients.
This is maybe not diversity related, but it's medication related. We see a lot of people online saying that you shouldn't be taking long courses of antibiotics, specifically doxycycline. Could you maybe speak to why we're put on such long courses of doxycycline and its properties?
Yeah, so doxycycline is an easy case to make about why sometimes, and we don't always, but sometimes we do use it long term. Doxycycline, while yes, being recognized as an antibiotic, it does have other properties beyond its beyond the pure antibiotic effect. Doxycycline has been shown to have anti-inflammatory properties. So it does reduce inflammation in the skin. And it's not just in hidradenitis suppurativa. There are other inflammatory skin conditions for which we use doxycycline. I can think of a good example, a disease called bullous pemphigoid. It's an autoimmune disease causing very itchy blisters on the skin. And it's one of the standards of care to use doxycycline in those patients. It is also used quite commonly in the treatment of acne. So that is the rationale behind using it from an anti-inflammatory side of its mechanism of action. When it comes to the antibiotic properties, and that applies to other antibiotics as well, what happens in HS is the lesions start as sterile lesions, but then there can be an overproduction or growth of bacteria within those lesions. And so that does change the biofilm in those tunnels. And that overgrowth of bacteria can also trigger more inflammation as the body is responding to the overgrowth of bacteria. So some of those antibiotics, they work by actually reducing the number of bacteria in the biofilm or in those tunnels. And by doing so, it helps in reducing the inflammation. In theory, that's probably why they work when we combine them with biologic therapies or immunosuppressive therapies, because those medications will reduce the inflammation, but potentially they can result in overgrowth of bacteria within the tunnels and fistulas of HS, and potentially the antibiotics can reduce that. So that provides that balance where we're targeting the disease from two different angles. The final note about doxycycline, and doxycycline belongs to a class of antibiotics known as tetracyclines. Some of the guidelines say, make it very clear that in select groups of patients, it is reasonable to use the tetracycline class of antibiotics long-term. So we know that, but it's nice to have it also in writing in guidelines produced by experts.
Thank you.
Well, we're maybe off the topic of diversity. I was just wondering if you remembered the first time that you saw HS.
Yeah, I think that I do have a vivid memory of a patient that I saw during my dermatology training. And it was a young female patient who came to the clinic. She's had HS for many years. It was misdiagnosed for a while as a skin infection. There were discussions during previous encounters about the role of hygiene and weight loss. But once we saw the patient and after thorough history and physical exam, we were able to diagnose her with the appropriate diagnosis. And then we developed a personalized management plan for that patient. And it was nice to see the patient's reaction to finally have a diagnosis and to have a better understanding of what causes HS and the treatments that are available. And then over time, seeing the response to treatment and how that had a significant impact on the patient and the patient quality of life.
Yeah, my doctors are so important to me. I can appreciate that story for sure. A bit of a follow-up though. So you learned about HS in medical school?
Briefly in medical school, we were exposed to HS. But in hindsight, I wish if we learned more in medical school about the disease, about its pathophysiology and about its associated conditions and about its treatments, because that, as someone who specialized in HS, that would have allowed me to help more patients early in my career and being more competent in recognizing and treating HS. I also think it is important for students in medical school to be exposed or to be taught about HS, even for those who are not going to dermatology, because the first encounter for many HS patients is not going to be with a dermatologist. It's going to be with the family doctors. It's going to be with the emergency physicians. Patients might end up with an infectious disease specialist or with a surgeon. So at least being able to recognize it and then referring the patient to receive the appropriate care. I think that is important. The other aspect of HS that I wish was taught in more detail in medical school would be the psychological impact of the disease. and how it can impact the quality of life of patients, and how early appropriate intervention can potentially have a huge impact on the patient trajectory when it comes to how productive they can be in life and to reduce the impact the disease can have on their quality of life.
I think I recall from the present. Sorry, Mike, were you gonna say something?
No. Please.
I thought it's been, I think, a year, but I thought when you did do the presentation at the Skin Spectrum Summit, that you said that do you screen your patients differently than the like, especially since you said, like Asians are in a section and that you would end up being in the white in your clinic? Do you screen skin of color differently?
To a degree, yes. So there's few aspects, and we did touch on them on the previous some of the previous questions, but I can expand a little bit more. One is at least my clinical observation has been is certain patient populations tend to have more severe disease at presentation, and especially South Asian patients, they can have quite a severe disease, and they don't necessarily have the same risk factors. They don't necessarily tend to be overweight, for example, which sometimes been linked to the disease activity in other patient groups. The other thing that I do is screening for keloid formation and trying to distinguish between the keloids and actual active lesions, because the active lesions we can reverse with appropriate treatment. And then the third is the signs of inflammation. So looking for those signs of inflammation that might not be as easy to detect in skin of color patients when it comes to that darker or dull color tone over inflamed skin rather than red, bright red inflamed areas. So those are the things that I tend to do, but it would be much better if we have more data about whether the comorbidities are different among different patient populations. It would be much better to know about the response to treatment and whether certain risk factors or demographic factors influence response to specific treatments.
How do you, so, the internet is wonderful and social media, but it does have a lot of propaganda and misinformation that goes with it. And I know my colleagues here have probably seen everything from, biologics are going to give you horrible side effects and long-term use can cause cancer to, let's take a bleach bath or whatever.
Yeah, or you can be cured with diet, things like that.
So how do you, stop some of this propaganda and really gain trust with patients that come in that aren't so, ready to get treatment or disbelief?
Yeah, it is something I certainly learned along the way, and I think the main thing when I meet with a new HS patient is to understand where they are in their journey. And so what is their understanding of the disease and what are their immediate needs, and then building on that. So for some patients, when we meet with them for the first time, their main focus is, oh, I have a very painful lesion. Can we take care of that? And certainly that's totally understandable. We can start with that and then build on it, where we say, and we can help you with this, and I would like to start some treatment to reduce your need to have another acute severe flare in the future. And then we can start that discussion about the disease and etiology of the disease and the role of medical treatments. In other patients, the patients just want to know more information about diet. And that's totally understandable. And being very frank about what we know and what we don't know about this. And when it comes to that, it is also important to make it very clear that some of the claims that are online might not be supported by evidence. But while we cannot refute all of them, there's probably some truth. Some of them we will need more research to show whether those interventions are effective or not. Now, some of the interventions that are out there, actually, we have data that to show that's not that effective. But to the most part, is patients the patients have lived with the disease for a long time. They've done research over a long period of time. So it's important that we take their concerns seriously, and then we try to have a mature conversation around those. There are other patients who are ready for treatment. There are patients they've had multiple courses of antibiotics, they've had multiple different treatments, and they want, is there anything new that they can try? And another patient might come and they want surgery because they think surgery is a cure for HS. So it's really about understanding where the patient is in their journey with the disease, and then meeting them at that point, and then working with them from there.
Before we say goodbye, Dr. Al-Hussein, do you maybe have any closing remarks for the community that will be listening?
Yeah, no, I want to thank you very much for the opportunity and invitation. And I want to also thank you for all the efforts you've been doing in raising awareness about HS and trying to help the patients out there with the disease in providing them with accurate information and helping them in advocating for themselves. So thank you very much.
Well, thank you so much, Dr. Al-Hussein, and thank you everyone for joining us today. Have a wonderful summer, and remember, real heroes don't wear capes.